So the title of my talk is Medical Therapy and How to Select Your Patients. But I thought firstly it would be useful to talk to you very briefly about the program, the 12-month program that we offer as part of Healthy Weight Australia. So, as I said, it's a 12-month program where initially when we see the patients, we do a baseline assessment for all their comorbidities. And it is very much a physician-driven program with the dietitian, psychologist, exercise physiologist, and we all work together. So I think that's one of the key things, is that we all work in the same place. And so when patients are having issues, we tend to talk to each other about what's happening as well. And so they get care from all of us from that perspective. We also have the gastroenterologist and obesity surgeon involved, and so they come once a month to our Rouse Hill practice, and so the patients get seen by everyone in the one place. And I think that's important to highlight, that it's not fragmented care. It's not care from a surgeon in one area and then they see another dietitian and psychologist somewhere else. That the important part is that we're all working together. And then in terms of, I guess, what pathways we go for each patient, it is very much focused on the patient, their current situation, what their BMI is, and what they're expecting out of this 12-month program. So often I get patients coming to me and they say, oh, I've decided this is what I want. And I think it's important to sit down with them with all their results. And so we do lung function and sleep studies as part of our assessment, as well as an echocardiogram and body composition. So if things get picked up along the way as well, we need to make sure that those things are treated. And yeah, like I said, it has to be focused to the patient. So we have to have that discussion as to what is the most appropriate pathway for that patient that's sitting in front of me. And often, for example, yesterday I had a patient come to me and say that yes, she wants an endoscopic sleeve gastrectomy, but in fact her BMI was 46 and she's 38 years old. And she's tried multiple pharmacotherapies, exercise, with no maintenance of weight loss. And so really following our discussion, we did agree that the best option for her to ensure longer term and maximum weight loss was in fact a laparoscopic sleeve gastrectomy. So those discussions are really quite important. So if anyone has more questions about our Healthy Weight program, we can address that later, and I will move on to the rest of my talk. So obesity in general practice, I think it's a really challenging topic for all of us. There's still a lot of prejudice and stigma attached to being overweight and having obesity. There's this thing called weight bias where there's a lot of judgment and the stigma, and that can affect, I guess, your view of the patient. And so there is evidence to say that health practitioners do have this bias where they think, oh, these patients have a lack of motivation, they're non-adherent to, treatments that you offer, that this is almost self-inflicted. And so if the patient perceives these views from us as their health practitioners, it makes it very hard for them to engage with us, and also that level of trust is not there. So I think that's one of the key things, that we all have to feel comfortable bringing these topics up with all of our patients in the right situation. Also, there's a lot of emotional issues with these patients. So again, you need to bring it up in a way that it is, I guess, appropriate for that patient and at that time. We have to identify obesity as a complex chronic disease with multiple comorbidities. We have a duty of care to bring up these issues with our patients, and it does require long-term care. So even though our program is 12 months, I don't think that the care ends at 12 months. It actually continues for the rest of their life. And that's also where I think general practitioners are really important in ensuring that care continues, because you are really the first port of call for patients. And again, the personalised approach and having strategies to approach the topic of obesity is really important. So this is the Australian algorithm for the management of obesity, and this was published 2 years ago now. As you can see, BMI is the criteria that we use. It has its limitations, but it's pretty much what we have at the moment. BMI above 30 is obesity, so 30 to 34.9 obesity class 1, then class 2 and above 40 is class 3. As you can see, there is a population-specific BMI, so slightly lower for Asian population as well as Indigenous Australians. So we do need to consider that as well when you see your patients. Initially, as we do, you have to assess their baseline complications, so whether it's medical, psychological or physical, such as osteoarthritis, which is something, I think we kind of tend to forget that might be related to being overweight as well. So then the pathway goes that if your BMI between 30 to 40 and there's no obesity-related complications, then this can be managed in the primary care setting. However, they do need supervised interventions. So whether there has to be a dietitian involved, and the lifestyle exercise plan should also be implemented. So there are dietary changes, such as the reduced energy diet and very low energy diets, as well as pharmacotherapy that can be initiated in that group of patients in the primary care setting. Moving on from that, if your BMI is above 30, between 30 and 40, if you do have complications, and then if your BMI is above 40, regardless of complications, I think that this should be managed with primary care as well as specialist care, because then you're getting into the higher risk area, and you do need intensive medical interventions. So that does involve dietitians and dietary modification as well as the exercise, pharmacotherapy, and then going down the line of considering bariatric procedures or surgery. So I'm just going to mention this very briefly, but the low energy diets are essentially to decrease your daily energy intake. The one that I guess we have the most involvement with is the very low energy diet, where you restrict to 800 kilocalories per day. Usually the partial regime, where they use 2 meal replacements per day with 1 meal mainly at night time, which consists of lean protein and vegetables, is what we usually implement. They're low in carbohydrate, so after a few days it can induce a mild ketosis and anorexic effect. Often it's recommended for 12 weeks. However, it can be continued for up to 12 months with careful supervision. And in terms of weight loss, average of about 2 kilograms over the first month, and after that 1 to 1.5 kilos per week. So there are a few contraindications. Pregnancy, if they've got severe psychological issues, recent cardiovascular event, porphyria, and if they're older. So in the older population over 65, you do need to use these with caution. And then special consideration, so diabetic patients who are on hypoglycemic agents, so whether they're insulin or sulfonylureas, the recommendation is to reduce the dose by about 50%. In patients with chronic kidney disease, you do need to be aware of electrolyte disturbances, so you'd need to monitor them a little bit more closely. And if they're on warfarin, the INR can get affected, so closer monitoring of INR. So when should you consider weight loss pharmacotherapy? So really, if the BMI is above 25, you classify as overweight. So I'm saying around over 27, because at this point it might assist with some initial weight loss. It might be used to maintain weight loss after they've done a very low energy diet, and then to prevent ongoing weight regain. Usually pharmacotherapies are required long-term, however we don't have a lot of long-term safety data or data in regards to the efficacy. At the moment, we have only 3 drugs approved by the TGA, and that's phentermine, orlistat, and liraglutide. So I'm going to briefly just speak about all 3 of them. So phentermine or duramine, I'm sure many of you may have used this in your patients. It's essentially acting adrenergic agonist that suppresses appetite. The indication for this is as a short-term adjunct with lifestyle changes, so diet and exercise. So those 2 things go together with all of these therapies that we would recommend. And in this case, when the BMI is above 30. It's contraindicated if they're on antidepressants and severe cardiac disease, including coronary artery disease, valvular disease, and arrhythmias. And if they've got hypertension or pulmonary hypertension that's not well controlled. So dosing is usually, we start at a dose of about 30 milligrams with breakfast, and that can be increased to 40 milligrams if they're tolerating the 30 milligram dose. It's registered for 12 weeks of therapy. Things to look for. So if you've got a patient who's been started on Duramine, what do you want to look for? Whether they're becoming tachycardic, hypertensive, insomnia, dry mouth, restlessness, and bowel disturbance. A weight loss of about 5 to 10% is expected with this medication. So orlistat or Xenical, again, another medication that inhibits pancreatic and gastric lipase. It reduces your fat absorption by about 30%, and it's indicated when your BMI is above 27 with complications or above 30 with no complications. It's contraindicated if they've had previous pancreatitis or major gastrointestinal surgery, or if they've got chronic malabsorptive syndrome as well, or cholestasis. So dosing, it's 120 milligrams. It's taken with food, so with your meal, and with a mildly hypercaloric diet. So there's no dose adjustment required in the elderly or if they've got hepatic or renal impairment. Things to monitor for, so steatorrhea, oil spotting and flatulence, particularly if they're having more than 30 grams of fat per meal. In the longer term, we need to be aware of deficiencies of the fat-soluble vitamins, so A, D, E and K. And again, long term, there is a slightly increased risk of developing oxalate kidney stones. So by inhibiting the absorption of this fat, it has been found to provide meaningful weight loss, and if you continue it for a longer term, that benefit is seen to continue. So I guess one of the newer medications that we have available is Saxenda or liraglutide. It's a human GLP-1 analogue, and it binds to and activates GLP-1 receptor. So GLP-1 is a physiological regulator of appetite as well as food intake, and the GLP-1 receptor is present in several areas of the brain that control your appetite regulation as well as in the intestine. It regulates appetite by increasing the feeling of fullness or satiety, whilst lowering the feelings of hunger. It also has effects on glucose homeostasis, and it may involve a minor delay in gastric emptying. However, it's not to be used in the context or for type 2 diabetes, so this is purely a weight loss medication. Liraglutide lowers body weight through the decreased food intake and loss of predominantly fat mass. So the indications for Saxenda are a BMI over 30 or between 27 and 30 again with complications, so pretty much the same as orlistat. And we've already talked about the weight-related comorbidities. If they've had previous pancreatitis, I would definitely not start anyone on this medication. There's also a warning for medullary thyroid cancer, which is rare, and also it's only been seen in mice and rat during the production of the medication. Patients over the age of 75 and also kidney disease, I would avoid this medication in. As I said, not for treatment of type 2 diabetes. It's also not recommended for treatment of obesity that's due to an endocrinological cause or whether there's an underlying eating disorder. It's Also, not to be used with other pharmacotherapies that we use for weight loss, such as the phentermine and the orlistat, and also not to be used with herbal preparations. There's no evidence for those things. So dosing. The starting dose is 0.6 milligrams. It's a subcutaneous injection that the patient administers on a daily basis, so roughly the same time every day. There is a dose escalation with this, so every week, or if they're not tolerating the drug, you can extend it to 2 weeks. You increase the dose by 0.6 milligrams until you reach a 3 milligram dose. If they just cannot tolerate the medication, then you might need to consider discontinuing treatment. And also, once they've been on that 3 milligram dose, which is the maximum dose for a period of 12 weeks, if they haven't had at least 5% weight loss, then the recommendation is that you stop Saxenda. So mostly patients either respond within that 3-month period or they don't respond. You do need to monitor for a few things. So nausea, vomiting are the main complications, and that's what really makes it intolerable for patients. Diarrhea, constipation, pancreatitis, again, is another thing to be aware of, and cholecystitis, tachycardia. So the obesity guidelines do state that if you look at just lifestyle change only, there's very few studies that show greater than 10% weight loss. And weight loss is difficult to maintain. So if we look at dietary change only, over a 12-month period, the average weight loss is 3 to 5 kilos. However, by 5 years, that weight loss benefit has gone. If they go through dietary change and exercise, at 12 months, average weight loss is 5 to 10 kilos. But again, by 5 years, that major benefit in weight loss is pretty much gone as well. So if we look at dietary change, exercise and psychological intervention, which is what we should all be doing, at the end of 5 years, there's a 3 to 4 kilogram average weight loss that's maintained for that period of time. I know those numbers aren't great, and so that's why we do need to consider the other things such as the pharmacotherapy and bariatric procedures. So this is where the lifestyle change in pharmacotherapy comes in. Again, not all the studies show that they have greater than 10% weight loss. Phentermine, along with the dietary change, the average weight loss at 12 weeks was 6.4 kilograms, but not a lot of data past that. Orlistat and dietary changes, so 2 to 3 kilograms at 5 years, and liraglutide and lifestyle change, average weight loss is 8% at the end of 12 months. So when should you refer your patient to a specialist weight loss clinic? So as we said earlier, BMI 30 to 35 with complications, and anyone with a BMI over 35. I think if you're considering Saxenda, it's always a good idea to get specialist involvement at that stage, and if they've got major psychological issues as well. Then if weight loss goals are not achieved with your lifestyle and pharmacotherapy, that's another reason why you should refer. And then if you don't have access to a dietitian or psychologist who has experience in these issues, then that's another reason why you should refer them. So in summary, obesity is a chronic disease that requires lifelong management. I think GPs play a key role in identifying those patients with obesity and then initiating the appropriate interventions to support their weight loss as well as preventing weight regain down the track. It's important to ensure that you as the general practitioner as well as your staff are educated in developing, obesity-focused practices, and even simple things as, having a weighing scale in your practice, and just as you check your blood pressure, check their weight periodically. So make it part of your day-to-day review of your patients. So of course, lifestyle changes are imperative, and pharmacotherapy may be required as an adjunct to weight loss and its maintenance. You should have a referral of specialist services that address these obesity and complications, and it's really important that we all work together to get the best outcome for our patients. I've just got some resources up, sorry. I think it's important for everyone to have resources, and we did mention that, you know, particularly obesity starts often in childhood, and I have put something there, Healthy Kids for Professionals, which is an Australian website, which has looked quite good in terms of support for children. Yeah, thank you.
Thanks, Shamani.